Imagine chatting with a perfectly alert, pain-free patient. Like they're sitting up in bed, their vitals look decent, and you're just, going through your standard admission questions.
Right, just a totally normal shift.
Exactly. But then less than 10 minutes later, you are standing over that exact same patient, driving the heel of your hand into their sternum, desperately trying to pump blood to their dying brain.
Which is just a terrifying shift.
It really is. That is
Yeah.
the high adrenaline reality of acute coronary syndrome. So welcome to today's deep dive. We are talking directly to you, the third-year nursing student over in Australia. We know you're prepping for your clinicals, and our mission today is to dissect the clinical simulation of a patient named Carl Shapiro.
Yeah, we are taking all that textbook cardiovascular theory you've been memorizing and throwing it right into the chaotic reality of a code blue.
Because it's one thing to read about it, right?
Oh, totally. We've pulled together a really specific stack of sources for this case study. We're working off a detailed, minute-by-minute simulation log of Carl's deterioration, plus the clinical feedback generated from that sim.
Which is super revealing, by the way.
Absolutely. And we're also pulling from the current Australian Resuscitation Council, the ARC guidelines, and a comprehensive set of cardiovascular pathophys notes.
Our goal here is to analyze that gap, between recognizing a theoretical risk and actually executing flawless, life-saving interventions in real time.
Right, because theory and practice are very different beasts.
So true. So we join the timeline at 15.0 hours in the Progressive Care Unit, the PCU. Carl is a 54-year-old male admitted from the emergency department with non-ST elevation acute coronary syndrome, or NSDE-ACS.
Okay, got it.
And when you read his initial SBR, everything gives you permission to just look away. He's alert and oriented ×4. His pain level is a flat 0 out of 10.
Zero pain is always reassuring.
Right. His vitals are essentially a smokescreen, though. His heart rate has settled down from 106 to 85. His blood pressure is coasting around 122/73. And his oxygen saturation is a perfect 96% on 2 liters via nasal cannula.
So, on paper, the initial ED interventions clearly did their job. He received oxygen, aspirin to inhibit platelet aggregation, and 2 doses of sublingual GTN.
Which is nitroglycerin, right?
Yeah, exactly. Which follows the standard protocol of a maximum of 3 doses spaced 5 minutes apart. He only required 2, along with a normal saline bolus, to just completely resolve his chest pain.
So if you merely glance at that dashboard, Carl is stable. But I want to push back on this a bit because clinical judgment demands that you look past that immediate presentation. You have to interrogate the background.
You really do.
Because Carl is a smoker. He's obese, he has a documented history of hypertension, and he routinely takes furosemide.
Ah, the water pill.
Yeah, that loop diuretic is the massive, flashing red flag hidden in plain sight. I like to think of it like an engine running on incredibly dirty oil, and someone has just, slapped a piece of duct tape over the check engine light.
That's a great way to put it.
Everything looks perfectly fine on the dashboard. But underneath, the entire system is actively primed for total failure. So if he's sitting there chatting, pain-free, why should a nurse already be on high alert just looking at this chart?
Well, all of his chronic risk factors, the smoking, the hypertension, the metabolic syndrome, they have chronically injured the endothelial lining of his coronary arteries. Atherosclerosis has been silently narrowing those vessels for years.
Just building up plaque.
Exactly. The physical narrowing restricts oxygen delivery, but the immediate lethal threat is the instability of that plaque. If the fibrous cap of that lipid-rich plaque ruptures, the body treats it as a vascular injury.
Oh, so it tries to heal it.
Right. Platelets swarm the site and cluster to form a plug.
Which is why the aspirin given in the ED was administered, right?
Yeah.
Specifically to try and blunt that exact platelet aggregation response.
Yes, it acts as a crucial line of defense. But if that aggregation outpaces the pharmacological intervention, the clot will completely occlude whatever minimal lumen remains. You lose distal blood flow entirely.
Wow. And you mentioned the furosemide earlier.
Yeah.
How does that compound the threat?
Right, so loop diuretics are notorious for causing significant potassium wasting. Hypokalemia alters the resting membrane potential of the cardiac myocytes. It delays repolarization, making the entire electrical conduction system of the heart incredibly irritable.
So you have a heart that is simultaneously starved of oxygen and electrically unstable.
It's a ticking time bomb.
And the simulation log tracks this exact physiological deterioration in real time, moving from that theoretical risk to the active crisis. The first subtle cracks in that illusion of stability start showing up on the monitor. You start seeing PVCs scattered across the strip.
Premature ventricular contractions.
Yeah, the ventricles are firing early, completely out of sync with the SA node, signaling that the myocardium is getting really irritated. Then, at 08.3, the clinical picture shifts aggressively. You ask Carl to rate his pain, and he tells you it's a 2, maybe 3, but it's getting worse.
That right there, that's the moment.
Yeah, his 12-lead ECG changes, now showing an inferior myocardial infarction, and his blood pressure begins sliding down to 106/63.
This is where we have to reevaluate our perception of the pain scale.
Right, because, a 2 out of 10 in everyday life is just a minor nuisance, right? I stubbed my toe. Why is a mild pain score suddenly the scariest thing in the room?
Yeah.
Shouldn't we be waiting for, crushing 10 out of 10 chest pain before we panic?
You'd think so, but no. In a patient actively being managed for acute coronary syndrome, returning pain of any number is a catastrophic finding.
Wait, really? Any number?
Any returning pain. It indicates active, ongoing ischemia. The myocardial tissue is actively suffocating. The interventions from the ED have either worn off or that ruptured plaque has completely overwhelmed them and occluded the vessel again.
Without that oxygen, the cells switch to anaerobic metabolism, lactic acid builds up, and the sodium-potassium pumps on the cell membranes just begin to fail.
And the failure of those pumps is the tipping point. The electrical gradients across the cell membranes collapse entirely. The ischemia triggers widespread, disorganized electrical chaos. The heart just loses its ability to coordinate a contraction.
Which brings us to 09.04 in the simulation. Carl develops ventricular fibrillation, or VF.
The big one.
Yeah, it's the most common dysrhythmia in adult cardiac arrest for a reason. The ventricles are no longer pumping, they're just rapidly and uselessly quivering. Cardiac output drops to absolute zero in a matter of seconds. Carl loses consciousness, his respirations cease, and his pulse vanishes.
And this is where assessment stops and protocol just takes over completely. The ARC guidelines dictate the rhythm of the room from this second forward.
So what's the very first move?
The immediate priority upon discovering an unresponsive, non-breathing patient is to assess the carotid pulse. You do not waste precious seconds searching for a faint radial pulse in the wrist.
Right, you go straight to the central circulation.
Exactly.
Once you confirm the absence of that pulse, you activate the medical emergency team, pull the emergency alarm, and immediately initiate chest compressions.
And the ARC guidelines mandate a strict ratio of 30 compressions to 2 ventilations, delivered at a rate of at least 100 compressions per minute.
But the raw numbers don't really tell the whole story. The mechanical execution is everything.
Oh, absolutely.
High-quality CTR is quite literally manually priming an old, stubborn water pump. You are physically forcing the blood out of the heart, up the carotids, and into the brain. If you stop pumping, even for just a few seconds to glance at the monitor or talk to the team arriving in the room.
Which happens all the time.
Yeah, all of that perfusion pressure you just desperately built up drops right back down to zero. You have to start all over again to build it back up.
And building that pressure back up takes multiple consecutive compressions. This is exactly why the guidelines hammer home the concept of minimizing hands-off time.
The sim feedback had a pretty crazy stat on this, right?
Yeah, in the clinical feedback from this specific simulation, there's a glaring metric. The primary nurse only performed CPR 79% of the recommended time.
Wow.
In a high-stakes code, a 21% hands-off fraction means the brain was completely devoid of oxygen delivery for over a fifth of the arrest.
That's terrifying. And that hands-off time, it accumulates in the margins, doesn't it?
Yeah.
It happens when you pause to slide the rigid backboard under the patient to give yourself a firm surface. It happens while someone is trying to place the AED pads.
Yes, you have to learn to coordinate those movements around the compressions, not the other way around.
Right. Keep pumping.
And the compressions also rely on full chest recoil. If you lean on the sternum and don't allow the chest cavity to fully expand between pushes, you fail to create the negative intrathoracic pressure necessary to pull venous blood back into the heart.
So if the heart doesn't refill, your next compression is just squeezing an empty pump.
Precisely. You're doing all the work for none of the benefit.
But compressions only buy you time, right? They won't fix the underlying electrical storm. To actually terminate the ventricular fibrillation, we need electricity.
We need the defibrillator.
And the safety protocols there are absolute. You must verbally and visually clear the bed, ensuring nobody is touching the patient or the frame, and you have to physically remove the oxygen source from the immediate area.
Because combining a high-voltage electrical shock with a pure oxygen environment is a massive fire hazard. You don't want to add a fire to a code blue.
Definitely not.
So the defibrillation delivers a massive depolarizing shock that essentially commands all the cardiac cells to reset simultaneously, hoping the SA node will take over as the primary pacemaker again.
But you don't pause to look at the monitor after hitting the shock button, right?
Never. The ARC guidelines require you to immediately resume chest compressions for 2 full minutes before performing another rhythm check.
Got it. And if the physical shock doesn't break the VF, we have to start relying on pharmacology to chemically force a reset. Adrenaline or epinephrine is our frontline medication here.
Yeah, the guidelines call for 1 milligram administered after the second defibrillation. It provides massive alpha-adrenergic vasoconstriction, clamping down the peripheral blood vessels to force whatever blood we are pumping centrally to the heart and brain.
The sources also note that vasopressin at a dose of 40 units via IV or IO can be substituted for the first or second dose of adrenaline.
Right, though adrenaline remains the standard algorithm pathway. But if the adrenaline and the electricity are both failing to terminate the dysrhythmia, we introduce amiodarone.
What does that do?
It's an antiarrhythmic agent that blocks potassium channels, prolonging phase 3 of the cardiac action potential, and aggressively stabilizing that irritable myocardial tissue.
Pushing these meds requires rapid access, though. And if you blow the IV or simply can't get a line established in a hypotensive centrally shunted patient, you don't waste time blindly poking them.
No, you move directly to interosseous or IO access.
You literally drill into the proximal tibia or the humeral head.
Ah.
The IO route delivers medications into the highly vascularized bone marrow, reaching the central circulation just as rapidly as a peripheral IV.
It sounds brutal, but it saves lives. And the orchestration of those compressions, the shocks, and the pharmacology finally yields a result in Carl's case. At 11.44, the monitor shows an organized rhythm and you palpate a pulse.
You have achieved ROSC, return of spontaneous circulation.
A huge moment.
Honestly, the adrenaline dump for a clinical student in that moment must be overwhelming. You see the sinus rhythm, you feel the pulse beating under your fingers, and your brain immediately tries to tell you the crisis has passed. Like, so we got a pulse back, the hard part is over, right? Now we just clean up the room.
That is such a dangerous assumption.
Yeah.
Succumbing to that relief is incredibly dangerous. ROC is exceptionally fragile. The patient has survived the arrest, but they are now entering the profoundly unstable post-cardiac arrest syndrome phase.
Because the body just went through trauma.
Massive trauma. The myocardium has been subjected to severe ischemia followed by reperfusion injury. The heart muscle is stunned. It's beating, but it is contracting weakly and ineffectively.
And you can see this failure immediately in Carl's post-ROSC vitals. His heart rate is hovering at 90, but the palpable pulse is weak and thready. His blood pressure is critically low, sitting at a terrifying 81/48.
The systemic hypoxia during the arrest has caused widespread vasodilation, dropping his systemic vascular resistance while his stunned heart fails to generate adequate cardiac output.
His oxygen saturation is struggling at 91% too. And he remains unconscious, only showing a purposeful response to painful stimuli.
So to combat that catastrophic hypertension, the team has to drastically increase his normal saline infusion from a maintenance rate of 25 milliliters an hour up to a wide-open 100 milliliters an hour.
Just flooding the tank.
Exactly. They were trying to aggressively increase his preload to give that stunned heart more volume to pump against. This level of physiological instability requires a flawless transfer of information to the intensive care team.
Which brings us to the handover. Your clinical SBAR handover in this moment is just as critical to Carl's survival as your chest compressions were 3 minutes ago.
No pressure, right.
Right. When the meat team arrives, cognitive offloading becomes the priority. The simulation feedback really highlights the specific dangerous errors students make when delivering this SBR while their hands are, still shaking.
It's so easy to do.
For instance, burying the lead by mentioning his history of hypertension, or the exact time the meat team was called.
Those details are important, but they muddy the waters if placed incorrectly. They belong in the background section. This situation must be a razor-sharp framing of the immediate crisis.
Like, this is Carl Shapiro. He suffered a VF cardiac arrest, received immediate CPR and defibrillation, and currently has ROSC.
Perfect. You anchor the team's mental model immediately.
Another common student error noted in the sources is bringing up the need for family education during the handover.
Again, very valid, but miscategorized. Family updates and education fall firmly under the recommendation phase. They cannot take precedence over physiological data when the guy's BP is 81/48.
The same applies to stating that the patient needs ongoing respiratory and circulatory monitoring. I saw that in the feedback too.
Yeah, that is a recommendation, not an assessment. The assessment phase is reserved strictly for hard quantitative data. You report the blood pressure of 81/48, the weak pulse, the oxygen sat of 91%, the specific infusion rate of the normal saline, and his depressed neurological status.
So the MATE team needs raw data to make immediate pharmacological decisions.
Exactly, like whether to initiate vasopressor infusions to support his collapsing pressure.
And the clinical recommendations moving forward establish a strict monitoring perimeter around him. You're initiating neurological assessments and full vital sign checks every 15 minutes.
You are essentially hawking the monitor because the underlying pathophysiology, the unstable plaque, the ischemia, the irritable myocardium, it hasn't been fully resolved. He could easily slip right back into ventricular fibrillation at any moment.
The role of the primary nurse does not end when the MIT team rolls the crash cart into the room. You are the historian. You hold the timeline. You know exactly how much adrenaline was pushed, exactly how long the patient was down, and exactly what the preceding rhythm was before the arrest.
And the precision of your communication directly dictates the efficacy of the advanced life support interventions that follow.
Man, we just walked through an incredibly intense, dynamic shift in clinical priorities. We watched a patient transition from chatting comfortably to requiring immediate, maximal life support.
It happens so fast.
We analyzed the hidden risks to the smoking, the hypertension, the critical potassium loss from the loop diuretic that primed the environment for an ischemic event. And we dissected the cellular cascade of how a mild 2 out of 10 returning chest pain signals the failure of the cellular pumps and triggers the lethal electrical chaos of VF.
We also translated the rigid ARC algorithms into physical reality. We explored the mechanical necessity of full chest recoil, the devastating impact of prolonged hands-off time, and the pharmacological strategy of using adrenaline to force central perfusion, followed by amiodarone to chemically stabilize the myocytes.
And we proved that securing ROSC is only the beginning of a highly volatile stabilization phase, heavily reliant on the structural integrity of a precise SBAR handover. You have to synthesize massive amounts of complex pathophysiological data while physically performing exhausting protocol-driven maneuvers.
It demands a really rare combination of deep theoretical knowledge and rapid, decisive physical action.
It really does. Before you step onto the floor for your next clinical rotation, I want to leave you with one final thought to explore on your own.
Okay, let's hear it.
The clinical documentation briefly notes that Carl is traveling for work. He doesn't live locally, and his family is hours away. So he went through this terrifying ordeal alone. But just imagine if the scenario were slightly different. Imagine if his family had been standing right there at the bedside when he grabbed his chest and his eyes rolled back.
The clinical requirements remain identical, but the environment becomes infinitely more complex.
Exactly. With the profoundly human task of supporting a family whose world is collapsing in real time. Because the reality of nursing is that, eventually, that check engine light flashes for all of us. And the people standing in that chaotic room are going to need your care and your clinical judgment just as much as the patient on the monitor. Keep that reality front and center during your training.
It's the ultimate test of both clinical excellence and human empathy.
Thanks for diving into the muddy waters with us today. Keep grinding through those clinicals, keep trusting your judgment, and we will see you on the next deep dive.